I want to start off by just saying a big thank you for the organizers for this meeting to have this opportunity to discuss cervical cancer and HPV vaccine. When I received the email, I said, yes, I want to come because it's an opportunity to create more visibility, really, and advocate for HPV vaccine. So my disclosure is that I have a grant from Merck evaluating HPV immunogenicity on adolescents living with HIV. And I'm a protocol co-chair and site investigator for the Kenya single-dose HPV vaccine trial. So I always, every time I go through this slide, I'm like, okay, this is not new, you've heard it before, but I want you to hear it again and again, because cervical cancer is truly a disease of inequity. And when we look at the global map, it's the lowest income countries that carry the highest burden of disease. While globally, it's the fourth most common cancer amongst women, in a large number of low middle income countries, it is the most common cancer amongst women of reproductive health. And in the last data, about 660,000 new cases took place every year. And I always like to break down these figures. I know we have them often, but whenever you break them down into daily cases, then you recognize what a huge burden. When I do the Kenyan figures in our population, they say we have 3,500 deaths. I'm like, that's a small van every day of women we're burying in my country from cervical cancer who need not die. And I like to add context with that because you look after children. And the majority of children are being looked after by women who get cervical cancer and die from cervical cancer. And I keep saying it's a cancer that need not happen, that need not kill women. So we've said already that the majority are LMICs, but I think the other aspect of it is because the East Asia has a much higher total population. They have the highest number of cases. So that's something else to keep in mind. And remembering that it's primarily preventive. We have a wonderful vaccine and screening interventions. There's a huge economic gradient. When you look at the map, the red areas you can see are mostly in East and South Africa, and that the mortality rates in Switzerland are 1 per 100,000 women compared to 55 or 56 in Eswatini. So I think we can agree it is a disease of inequity. Now, while I was talking about cervical cancer and vaccine and prevention, because it is an HIV meeting, I thought I'd talk a little bit about these twin viruses and the interplay that they have between them. And again, when you look at the world map, the highest burden of cervical cancer is in countries with the highest burden of HIV. And that women living with HIV have much higher prevalence of both HPV and HIV co-infection. They have more persistent infection because HPV, lots of us get HPV, I think 80% after initiating sex within 3 years, but most of us clear it. And the thing is that when you're immune suppressed, then you don't clear it. And that women living with HIV have a much higher disease progression from infection to precancer to invasive disease. And cervical cancer is recognized as an AIDS-defining illness. There's a significant amount of cervical cancer that can be attributed to HIV, and in Kenya it's estimated in this paper to be about a quarter of the infections can be attributed to HIV, which means if we brought HIV down, we could bring cervical cancer down. And I don't know if I put the slides there because there's also data showing that the presence of HPV increases the risk of HIV by twofold. We don't know if the vaccine would reduce that. But it's one of the preventable cancers. We know what causes it. It's high-risk HPV infection. We have really simple tools, which are supposed to be low cost, for screening pre-cancer and interventions to prevent it moving to cancer. But the challenge has been implementation of these interventions. And different from many, many cancers, is diagnosed early, we can cure it. But we still haven't been able to do it. So in 2018, looking at all that, the WHO came up with the 1970 elimination strategy, and they proposed that if we vaccinated 90% of age-eligible girls by the age of 15, screened at least 70% of women twice in a lifetime with a high-performing test like HPV, and treated those with lesions, we could move very close to elimination. But it might not be as easy as having the intervention shows. And in countries with high burden disease, like above 40, it's been shown that vaccination alone would take us over 100 years. So we need to both vaccinate and screen to have real impact for those countries. But countries with lower disease burden can quickly move to that spaces. So with these interventions, we can reduce burden of cancer by a third, and by 2070, 92% with both screening and vaccine. There's this strategy called HPV Faster, and then it was called HPV Even Faster. And this is a combination of vaccination and screening, because the risk of HPV infection persists through somebody's sexual life, and so long as they're sexually active, they have risk of infection and progression to cancer. And a lot of the proof of concept early trials included sexually active women up to the age of 26 years. And recently I was talking to one of our colleagues in Kenya, and he said to me, but the program, the vaccine program says we only vaccinate up to age 14 years. Does not mean that you shouldn't, it's not useful if you're older. So sometimes when the program gives a certain age range, it sends a message. That's not always the correct one. And then they also propose universal vaccination, and it's also called gender-neutral vaccination, but that language of gender has brought a lot of stigma and bias. And somebody said, but we don't have gender-neutral hepatitis B vaccination, we just vaccinate everybody. So in this HPV Faster strategy, we continue to vaccinate everybody 9 to 14 years, but also expand the age band up to 30 years. But there are other countries, like a lot of Western countries, are also offering it up to women of 45 years and have a concurrent strategy to make sure that we're screening women above the age of 25 years. Now, I know a lot of people here are pediatricians and you're seeing the babies, but I'm asking you to remember the mothers also, because baby survival does depend on mother's survival. So I'll move to the subject that I was supposed to speak on, which was vaccination, which we said we can have, if we can vaccinate 90% by age of 15, and these children are in the adolescent care, we can move this strategy of elimination. This is a vaccine that works well. It works really, really well. And I always compare it usually to measles and other vaccines, and I think those are less than 90%, 86. So this vaccine across trials has had a vaccine efficacy of up to 96%, in some of them up to 77%, not just in prevention of the high-risk vaccine type HPV, but also pre-cancer lesions. And more recently, we've started seeing population impact on the endpoint of cancer, which of course takes a much longer time. And the factors that drive the vaccine durability and efficacy is that it induces high levels of neutralizing antibodies, which evoke robust memory response with what Margaret Stanley loves to call long-lived and lovely plasma cells and reactive memory B cells. And the virus itself is highly susceptible to the neutralizing antibody. And actually, we don't even know what the threshold, how low the threshold needs to be for the vaccine to stop being effective. And in animal trials, low levels of antibodies have continued to be protective. So in some of the proof of concept studies, now they're showing us data. That slide showed up to 11 years, but last year, the Costa Rica trial showed data up to 19 years, where the antibody levels have plateaued and be sustained and continue to be protective. I give these data from a trial that we did that we vaccinated adolescent girls and boys aged 9 to 14 years, and we gave them the 3 doses of vaccine. And though initially there's a little dip, there's been a plateau throughout. And I'm not showing this data now, but we followed this cohort up to 9 years post-vaccination, and they have sustained their antibody response, and they have stayed protected from HPV infection. So people living with HIV still retain a robust and safe immune response to HPV vaccination. And I've talked about what happens about the slow decline and then the plateau for long durations. But we don't have data on clinical outcomes for people living with HIV. There's still a paucity of data. So I cannot talk about HPV without talking about the single-dose trial data, which is really important because we have remained to have low global coverage. And we think that a strategy of a single dose is easier to deliver. We can increase global population level coverages, and we can even target multi-age cohort and expand beyond the age of 14 and move to elimination strategy. At a shorter time, you deal with vaccines more than the rest of us, and you know that multi-schedules are more complicated to deliver. So the trial I've been involved in is the Kenya single-dose Kenshi trial, where we looked at Cervarix, the bivalent and the nanovalent vaccine, and demonstrated efficacy levels of up to 97 or 98%. Then we have the other 2 trials, which were observational trials from India and Costa Rica, which are the ones that drove that idea that 1 dose may be enough. Now, what we've seen, this is what I was talking about from the other trials, is this sustained immune response of antibodies and above the threshold that is seen in natural infection. We know that natural infection does not induce enough immunity to be protective, that women will get HPV 16 and still be infected again. These are my lovely colleagues in Kenshi. I'm always proud of them, so I like to show them up. And we are following this cohort now up to 5 years, and we continue to show high efficacy for the single-dose HPV vaccine amongst young girls who are age 15 to 20 with 1 dose at vaccination or sexually active. And last year, we then vaccinated everybody. The children on meningococcal vaccine also received 1 dose with nanovalent, and we haven't seen infection in that group. And this group was up to the age of 23 years at the time of vaccination. So I always say this vaccine just works really, really well. So WHO revised the recommendations in 2022 with our data, and it reads that 1 or 2 dose schedules at least 6 months apart, which is if you do 2 doses, please don't do it shorter than 6 months. It can be even a year longer. You can delay for however long you want for women and girls between the age of 9 and 20. We don't have data for boys for single dose, but remember we have data for boys for higher dose schedules. And for those who are immune compromised, we're still on a 3-dose immune regimen. And I'll just touch on that a little bit because when national programs move to single dose, we really have to think about how do we then give the additional dose, and I think most people are on 2 doses now, to the children living with HIV, because we don't have data to show that 1 dose works for them. I show this monogram as a reference. It has a lot of beautiful articles on vaccine implementation and screening integration. So nearly half countries that have recently introduced HPV vaccine have adopted a single-dose regimen. And what's really lovely about this is that countries with very high populations like Bangladesh and Nigeria have been able to launch HPV vaccine programs because they could pay for it. And now when you're a middle-income country in Africa, you don't have the advantages of a Gavi vaccine, so they have to buy it. In addition, Western countries like Australia, Ireland, and the UK have also adapted to single-dose regimens. So this has really expanded global coverage. But coverage still has been fairly low. So we have to think wherever we are, and that's why I'm here, happy to be here, to see what we can do to increase coverage and make sure that young women are protected from this. I picked this up because I showed a lot of the other slides, but these are work from Uganda that looked at what are the barriers to HPV vaccine uptake, and the individual barriers, health facility barriers, and community barriers. There isn't much knowledge about HPV vaccine. And most of the programs now are delivered at schools. So for children who are out of school, they do not get vaccinated. There's fear of injection, there's peer influence, there's a lot of malinformation about HPV vaccine. I think we've heard it about fertility. And I like to tell people the problem we have in Kenshi, we give contraceptive, but a lot of our girls have been pregnant, up to 40%. So I can tell you that these are not true. Even within health facilities, our healthcare providers are not knowledgeable, and I think the vaccine is not part of curriculum, is it? Is it? At least not in our country. So I think that's something we should aim to change. How do we make sure that HPV vaccination knowledge is built into our curriculum so our healthcare providers have vaccine confidence? Sometimes the healthcare providers are not quite friendly. And this issue of multi-dose is also a barrier. On community levels, there are concerns about safety. We've had gynecologists in Kenya going on local radio to say that the vaccine causes 240% risk of ovarian cancer. You know that's not true. It doesn't make sense. But he's a doctor, very elegantly dressed, and therefore very convincing at the community level. But we don't have resources to rebut this malinformation. Most of our programs are funded at the beginning, but they don't continue being funded thereafter. This data is from a study, again, from Uganda, and they found that only 61% of the girls living with HIV had been vaccinated. 31% with 1 dose, 22% with 2 doses, and 8% with 3 doses. So you can see we have a gap. Again, limited knowledge for both girls and their parents. And they've seen across studies and in our own studies that parents and caregivers have very high influence on whether or not the child will be vaccinated. So caregivers of unvaccinated participants were more likely to accept and internalize negative community narratives, especially if they are aligned to social anxieties. And of course, issues of infertility are huge on society level value systems. So how can we do this? On individual level, we can increase peer-to-peer education, enhance linkage to vaccination, move forward with the single-dose schedules, enhance the school delivery programs, and have community education programs. In Kenya, I didn't put it here, the Catholic Church actually sent out a statement this year, we were very happy, to say that the vaccine is safe and it's important that we save and protect lives. But that didn't just happen. There was a lot of advocacy work. I went to a meeting where one of our advocates had nuns and priests from the region sitting with us for a whole day to really advocate and educate on the vaccine. So I like to put this up because sometimes we forget these populations, people who are nomadic and people living in high-density neighborhoods. Often these girls are the ones who are out of school. So I'm about to end, but because we're in Rwanda, I'd be remiss not to talk about the Rwanda's success story. And Rwanda was one of the first African countries to implement a national HPV vaccine program in 2011, led by their first lady. They've continuously had really high population level coverage. They started off with a younger cohort up to 12 years. Then they went up to the secondary schools and did the multi-age cohort and have reached a coverage of 94%, so way above what has been proposed. And they've been doing these serious surveys using urine to evaluate the amount of vaccine type HPV infections. And even they've noted that there's been a huge reduction from 12% of prevalence to 5% on repeat surveys on population levels, with an adjusted vaccine efficacy of 47%. and 24% for girls living with HIV. So this is something that needs to be done. The first population level impact data was done in the West, and they looked at 9 income countries where coverage was above 50% and less than 50%. When coverage was above 50% and amongst girls less than 20, the reduction in HPV 16 and 18, which caused 70% of the cancers, was 68%. And anogenital warts by 61%. But there was also concurrent reduction in warts in boys, with a heart protection of 36%, and even a reduction amongst the older girls. So population coverage is really important. But when the coverage was below 50%, the vaccine efficacy reduction was lower at 50, and then the other girls was 14, and there was no cross protection. So we need higher coverage. This data was recently presented, actually last year in Sweden again, and they looked at 1 dose, 2 dose, and 3 dose. And what you will see, I don't know if I can point it, you can see that it works best when the children are vaccinated at the ages of 10 to 14. I don't know if I have a pointer. But you can see it for yourself, and that the intervals, confidence intervals are very close for 1 dose, 2 dose, and 3 doses. But for those at the age of 21 and 35, the 1 dose did not work quite as well. This is the HOPE trial was in South Africa. It was, they had a catch-up vaccine program, and amongst girls 15 to 16, and they looked at the impact of 1 dose on a population level. At that time, the overall coverage was 20%, and you can see that there was those, you can look at people without HIV and people living with HIV, and the differences were quite substantial, pre-survey and post-survey. So there's less impact, there's less effectiveness for people living with HIV, but with a single dose, the HPV vaccine efficacy was 64% on a population level. And I think one of the slides I don't have here is a reminder that infectious disease need us to reduce the amount of virus at a population level. So the more people we vaccinate, the more we reduce the circulating virus, the higher impact we'll have. There's been ongoing work on a therapeutic vaccine. I think if it gets investment, it'll be very exciting, because remember the HPV vaccine is prophylactic. So if we could find women who self-sample, have HPV, and get a therapeutic vaccine, plus a prophylactic vaccine, I think that would be amazing. We don't need to do speculums anymore. So this work is still ongoing. Nobody likes them. I like to do them, but I don't know if anybody likes to get them. Okay. So in the HPV world, related to cervical cancer, we know a lot, but we implement really poorly. Amongst people living with HIV, we have I didn't show that data, but there's very high recurrence of precancer lesions. But the vaccine remains highly efficacious, very safe, across all populations. We'll have to figure out. I think 2 doses are enough. There's data now, I think, coming from Eswatini. We should see. Oh, it's your data. Yeah, you tell us. Is it working? 2 doses? For most. For most, yeah. But we still need to figure out how to give that second dose, and then we need to do trials to find out what happens when people living with HIV get 1 dose. So we're still not there in finding the right implementation strategies for people who need HPV, prevention of HPV-related diseases. And I added this, that I still dream of a day when we'll have both a prophylactic and therapeutic vaccine with population coverage of screening. And then we only need medical treatment, and we don't need surgical interventions to treat people with precancer lesions. But we've seen amazing things in this world. I saw the single tablet for adolescents, for children, and for really young children. So I think all these things are feasible. But for now, I think it's important we try and make sure that whoever comes within our arena of care, we promote vaccination. It's available. It works really, really well. I asked several people, and the late Lynn Denny, bless her soul, rest in peace, she said it's important that we prioritize women's health. And we know that children's health is tied to women's health. So fighting HPV infection is critical for us. And Margaret Stanley always says that we just have a really wonderful vaccine, and she has great confidence in the one dose because of its lasting durability and the plateauing antibodies. And we have a real hindrance when it comes to how we will eliminate cervical cancer with high failure rates amongst women living with HIV for treatment of precancer lesions. That's PATHA. And Nyarato was here with us. She told me that we really need a lot of north-south, south-south collaboration to strengthen capacity, minimize inequity. And Gure reminded us of what we did during COVID, when the world moved together to work against one disease. So if it takes a combined, concerted effort of dedicated, committed people, that's what's taken us this far, but it can actually take us to disease elimination, and it's feasible. So those are my colleagues in Thika from our trial site, and I thank all of you for inviting me here and for listening to me, and all the funders and people who volunteer to be in our studies. Thank you.